we provide care to the total patient. We treat the patient and not the disease itself.
One of the biggest differences that you might find coming to Lewistown Hospital's Cancer Treatment Center as opposed to one of the bigger metropolitan centers is because we're smaller, we're able to focus in on that patient as opposed to just being a number that's caught into the system.
Oh, there's no doubt about it. This hospital has had a terrific vision of providing the very best, very excellent cancer care by purchasing the new CT scanner and the complementary radiation oncology facility. They work hand in hand, and there is no better within 100 miles.
They come in a very private parking lot. They come into our facility. They're taken care of on a very personal one-on-one basis, and they're followed from their entire course from the first day right through to their last, and we include our follow-ups for many years beyond that treatment.
My name is Dr. Bernard Rogers. I'm the radiation oncologist and the medical director of the Lewistown Cancer Treatment Center.
I'm Matt Quiderovich. I'm the department manager at Lewistown Hospital's Cancer Treatment Center. I'm also one of the radiation therapists that would be involved in delivering treatment. The technology that we have here is the same type of technology that you would find at a center such as MD Anderson, John Hopkins. What we deliver here, though, is the same exact type of therapy with the same exact type of equipment to deliver the same exact type of results.
Now, the first step in patient evaluation is the person will see one of two oncology certified nurses. This is the first step in our evaluation of treating the patient and not the disease.
The nurse will pick them up from the waiting room, and then they'll spend approximately 30 to 60 minutes just reviewing the history, any sort of conditions that they'd like to speak about, and any sort of miscellaneous things that would be appropriate for our oncologist to know prior to him even getting into the room. Once Dr. Rogers enters the room with the nurse and the patient, he will review all of their systems, meaning anything that the patient might have wrong or a condition that might have brought them here, as well as review any sort of nursing notes that were taken prior to him entering the room. The physician will spend time with that patient then reviewing all the options that might be available to them. We've got many options available to us here, which includes brachytherapy or any sort of external beam radiation. The patient can then make their choice, make their decision on what type of therapy would be most appropriate for them, what they would be most comfortable with. Once that decision is made, they'll go back out to our receptionist and she will make an appointment for them to come back to the facility. Next time the patient enters the facility, it will be for the simulation. We want to make sure that we're treating just the area that we need to, nothing more, nothing less. So there's various things that the patient as well as the therapist will be involved in to try and make them comfortable, but also make sure that they don't move during their therapy. The simulator becomes more of a staging area for going through the treatment as a trial run before anything is delivered on the linear accelerator itself. So there'll be several appointments in the simulator room. The first appointment involves setting the patient up for any type of immobilizers that the physician feels is warranted in order to be able to treat them and keep them comfortable and not have them move during their therapy. Once the patient's immobilizers are established, the patient does undergo a process that uses our 64-slice PET-CT.
This 64-slice PET-CT allows us to intimately use this PET-CT to evaluate the tumor margins, the total extent of the tumor. Not only this, but it does it in a very rapid fashion. That is, the patient doesn't lie on a table for a very long time, which in itself causes some disability.
64-slice PET-CT or positron emission tomography involves putting the patient in the treatment position and scanning through the area that we need to treat. The reason for that is because we want to be able to look at that patient in a three-dimensional view. Once the simulation appointment is complete, it's generally about a week before the patient would actually start their therapy. Reason being, there's a lot of behind-the-scenes checks, final tweaks that our physics department as well as our oncologist undergo to just further define that treatment for the patient.
Our treatment planning process intimately involves a dosimetrist as well as a physicist.
I'm Dave Nelson. I'm the medical physicist at the Community Cancer Center. I have a PhD in medical physics and I'm board certified by the American Board of Medical Physicists. Our focus is to design a treatment plan that is optimized for each patient, and we want to make sure each treatment is delivered according to that gold standard. That means the treatment that we design for them is going to be the treatment that they receive.
The dosimetrist is another integral person. These are where the calculations are performed. After I have indicated how much radiation I want to give to a specific area, it is Cal, the dosimetrist, that does the actual computations and then shows them to me for my approval.
Welcome to the Radiation Oncology Department at Lewistown Hospital. My name is Cal Hassan and I am the certified medical dosimetrist here at the Community Cancer Center. I also have the benefit of holding a master's degree in physics and being certified as a radiation therapist. Basically what the dosimetrist does is once the doctor has defined the tumor volume, either Dr. Nelson, who's our chief medical physicist, or I will design a treatment plan that tries to maintain that delicate balance between delivering the radiation dose and taking into consideration all the sensitive normal structures around the tumor that we want to spare. I sit with Dr. Rogers, we review the CT scan, the MRIs, the PET scans, whatever images we have, depending on where he defines the tumor volume he wants to target. My role then is to find the optimal field designs that will achieve that while at the same time protecting all healthy tissue around it. My dosimetry training was at Roswell Park Cancer Institute up in Buffalo, and it is a very big center up in Buffalo that does a lot of cancer research. So coming to Lewistown when I interviewed, expecting a small regional hospital and regional cancer center, I was kind of surprised at the level of technologies that they had at such a small clinic. They are definitely up to date. They have a lot of machines at their disposal. I can do anything from a simple 2D treatment plan to a 3D conformal, IMRT, which is intensity modulated radiation therapy, which basically allows me to shape the radiation and deliver it precisely to the tumor the way I want it to, which is a significant benefit for these patients. A treatment plan that would usually take 20 to 30 minutes to deliver now can be delivered within 3 to 5 minutes.
Yeah, we have some of the best technology that money can buy here in Lewistown.
Part of the reason I came into this field was because it started out with my dad, who had a brain tumor, and at the time I felt helpless and didn't know what to do. So it definitely hit home, and I feel that connection with every patient. Every patient is my father, every patient is my daughter, because my daughter too also has benign tumors that grow. So for me it is personal. A patient is not a tumor, it's not a lung cancer, it's a father, a husband, a wife, a mother.
HDR stands for high dose rate, and that is our brachytherapy program. What HDR is radiation that's delivered from the inside out. There is a source of radiation that sits in a piece of equipment called an afterloader, and in that afterloader there's a source that's attached to a wire, and on the end of the machine there is holes that hollow tubes attached to, and those hollow tubes go from the machine to the patient. The patient will enter the room and be hooked up to those hollow tubes.
we can insert these directly into the tumor itself.
What happens at that point then is when the radiation is turned on, that source of radiation passes through those hollow tubes and is delivered to the patient's area that needs to be treated.
This machine allows us to deliver a very high dose of radiation over a short period of time, being a matter of 5 to 6 or 7 minutes. We used to have to keep the patient in the hospital for 4 to 5 days for this same type of treatment. But these days, technology has advanced so much that we can do this treatment in a matter of just a few days and a few minutes. This new linear accelerator we have is called a Trilogy, made by the Varian company. It allows us to give treatments in a much more refined fashion than previous. Patients will frequently take only 5-minute treatment, even less, whereas before they would take 20 minutes.
When a patient's put under the linear accelerator machine, they just lie there comfortably. There's no pain, there's no smell, there's very little sound involved. And what happens is a type of radiation called photons come out of the machine, and this is a radiation that goes from the outside in, which then those photons affect how the patient's cancer actually is treated.
It develops several highly technological features such as rapid arc and IMRT radiation.
And probably one of the biggest advantages of this new machine is some of its imaging capabilities. We're able to really focus in on the treatment area while the patient's on the treatment table itself and be able to adjust each day for that patient's treatment to make sure the way that the treatment was planned from that very first day with our physics and doctor right through the last treatment. Patient tumors move from day to day, so having that image guidance on a daily basis is a huge advantage for that patient's overall therapy.
This new linear accelerator allows us to do another special type of examination called cone beam CT guided radiation therapy, which is having a CT scanner on the treatment table. We do this type of treatment before we actually give the radiation treatment itself. This allows us to exquisitely adjust to the geometry of the tumor. This technique allows us to treat circumferentially, that is 360 degrees. The machine itself will go around the patient, and as it goes around the patient, it turns itself on and off. The reason it does this is to avoid sensitive structures, and at other times turn itself on to give a 360-degree treatment. Now, this in itself confines and solidifies the treatment without giving an overdose to the normal tissues.
Once we put the patient in their treatment position, they have no worries as far as moving. They just lie there, relax, breathe normal, and everything then rotates around them to ensure that they're getting the perfect treatment day after day. Probably the biggest attribute that we can say here at our Cancer Treatment Center is that everyone is patient-focused. Everyone is here for one reason and one reason only, and that's to take care of our patients.
You can either look at these patients as nothing more than a parotid tumor, but parotids don't have families, people do. And if you keep that in mind, you're going to always design a plan that you would design for your own family member. And that's what I think is important.
Well, certainly, I feel that I am certainly proud to be a part of this institution. We, as I said before, we provide care to the total patient. You treat the patient and not the disease itself. At this institution, you are not a number. You're a person, you're not a disease. And we have a very caring group of about 10 of us that deliver care in an excellent fashion, both socially, psychologically, and biologically.